I was told to clear beds and move bodies along. I had a patient who could not walk and no diagnosis that fit the forms. The system wanted certainty, not hesitation, and I had neither to give. So I chose delay, knowing it would cost her something I could not measure. In the late summer of 1945, several weeks after the formal surrender of Germany, Allied military administration in Central Europe shifted from combat operations to occupation and humanitarian stabilization. The front lines had dissolved, but their consequences remained visible across towns, rail corridors, and improvised camps that stretched from the Rhine eastward. Millions of displaced civilians and prisoners of war were being processed, repatriated, or held temporarily while Allied authorities assessed their status. One such site was a former German military hospital complex on the outskirts of a medium-sized town in southern Germany. The facility, originally designed for Wehrmacht casualties returning from the Eastern Front, had been taken over by U.S. Army medical units in May. Its wards were no longer reserved for soldiers alone. They now housed a mixture of former enemy personnel, civilian refugees, forced laborers, and detainees awaiting transfer. The hospital operated under strained conditions. Power was intermittent. Sterile supplies were limited. Records were incomplete or missing entirely. Many of the German medical staff had fled or been detained, leaving American doctors and orderlies to manage unfamiliar equipment and patients whose histories were fragmentary at best. Captain Harold Weiss, a 34-year-old U.S. Army Medical Corps physician, had been assigned to the facility as part of a rotating occupation detail. He had trained in internal medicine before the war and had spent much of 1944 treating combat fatigue and shrapnel wounds in France. By August 1945, his responsibilities were less dramatic but more complex. Intake evaluations, triage of chronic conditions, and assessments of prisoners of war who required medical attention before transfer to holding camps. Each morning followed a routine. Weiss reviewed overnight reports, conducted ward rounds, and signed off on transport clearances. Most cases were predictable: malnutrition, untreated infections, lingering injuries from bombings or forced marches. The work required patience rather than urgency, and Weiss approached it methodically. On the morning of August 18, he was informed by a sergeant that a new intake group had arrived overnight from a nearby screening camp. Among them were several women classified as civilian auxiliaries attached to German logistical units during the final months of the war. They were to be medically evaluated before reassignment. Female detainees were still relatively uncommon in Weiss's ward. When they did appear, they were usually clerks, nurses, or factory workers swept up in the collapse of German administrative structures. Most were exhausted, but otherwise physically intact. One name on the intake list stood out only because of an annotation beside it: limited mobility, non-ambulatory. The patient was identified as Anna K., age 26. Her file was thin, consisting of a handwritten intake card completed by a processing officer who had not examined her in detail. There was no diagnosis, only a note indicating that she had been transported on a stretcher and required assistance standing. Weiss made his way to the women's ward shortly before midday. The room had once been a recovery area for surgical patients. Now it held 8 iron-framed beds spaced evenly apart, with thin partitions between them. Anna K. occupied the third bed near the window. She was awake when Weiss approached, sitting upright with her hands folded in her lap. Her posture was rigid. Her uniform, a faded gray dress typical of late-war auxiliary issues, had been replaced with a hospital gown. Her boots were neatly placed beneath the bed. Weiss began as he always did, confirming name and age, asking routine questions through an interpreter stationed nearby. Anna's responses were brief and precise. She reported no current fever, no respiratory symptoms, no recent injuries from combat or bombardment. Her pulse and blood pressure were within normal limits. There were no visible wounds. When asked about her mobility, she hesitated. The interpreter repeated the question. Anna replied quietly that she was unable to stand or walk without assistance. Weiss asked whether this was due to pain, weakness, or injury. She shook her head and said she did not know. Weiss requested that she attempt to move her legs. With visible effort, Anna shifted slightly on the bed, but her lower body remained fixed in position. There was no sign of paralysis. Her feet responded to light touch, and reflexes appeared intact. yet her thighs remained pressed tightly together, her knees rigid. The interpreter relayed Anna's explanation with some difficulty. She stated that she could not separate her legs. When asked how long this condition had persisted, she estimated several months. She denied having been wounded. Weiss made a note and proceeded cautiously. In the aftermath of the war, he had seen numerous psychosomatic conditions, temporary blindness, muteness, tremors, that had no clear physical cause. Stress and trauma often manifested in ways that defied textbook descriptions. He asked whether she had been examined by a physician previously. Anna answered that she had been seen once, late in the war, but that the examination had been brief and inconclusive. She had been returned to duty shortly afterward. Weiss completed the rest of the evaluation without pressing further. There were no signs of infection or systemic illness. He ordered routine blood work and requested that Anna remain under observation. Over the next several days, Weiss encountered Anna repeatedly during his rounds. Her condition did not change. She ate regularly, slept poorly, and remained unable to stand without assistance. When nurses attempted to help her walk, she became visibly distressed, her muscles locking further rather than loosening. Other staff members offered theories. One orderly suggested hysteria, a diagnosis still commonly applied to women exhibiting unexplained physical symptoms. A nurse speculated about pelvic injury sustained during bombing raids. None of these explanations fully accounted for the presentation. Weiss reviewed what little background information was available. Anna had been assigned to a supply unit in early 1944 and had spent the final year of the war moving westward with retreating German forces. There were gaps of weeks in her record where her location was unaccounted for. Such gaps were not unusual. On August 24, Weiss attempted a more thorough physical examination, again with the interpreter present. When he explained that he needed to assess her range of motion, Anna became tense but did not refuse. As he approached the lower examination, she spoke at length, her voice low and controlled. The interpreter translated slowly. Anna stated that any attempt to force her legs apart caused severe pain. She added, without inflection, that she could not close them any further than they already were. The statement was delivered as a matter of fact, not complaint. Weiss paused the examination. He had no reason to doubt her description, but he also had no immediate framework for understanding it. There was no visible swelling, no obvious skeletal abnormality. For the moment, he ended the assessment and ordered additional observation. By the end of the week, administrative pressure began to mount. The hospital was expected to clear non-critical patients to make room for new arrivals. Weiss was asked whether Anna could be transferred. He answered that her condition was unresolved and that further evaluation was necessary. There were no specialists readily available. Surgical units had been redeployed. Gynecological expertise was limited. Weiss was left with a patient whose symptoms did not conform to any single diagnosis he could confidently assign. On August 27, he noted in her chart, mobility restriction of unclear origin, patient cooperative, no evidence of malingering, recommend continued observation. The entry was factual, but it reflected an underlying concern. Anna's condition was not improving, and the explanations offered so far were insufficient. Weiss was beginning to suspect that the problem was not one of simple injury or fatigue, but he lacked the information to pursue the matter further. That afternoon, he stood briefly at the foot of her bed, observing her posture and expression. Anna stared out the window at the hospital courtyard, where other detainees moved freely under guard. She did not look at him. The ward bell rang, signaling the end of visiting hours. Weiss turned away to attend to the next patient, leaving Anna as she was, her condition unchanged, her history still largely unknown. By early September 1945, the pace of admissions at the hospital increased again. Allied screening operations were accelerating, and detainees deemed medically unfit for transport were being diverted in growing numbers. Bed space became a point of daily negotiation between medical officers and administrative staff. Each unresolved case represented a delay in the system. Anna K. was one such delay. Captain Weiss was asked twice within a single week whether her transfer could be authorized. Each time he declined. Her inability to walk unaided made movement to a holding camp impractical, and no clear diagnosis had yet been established that would justify classification as chronic or permanent disability. She occupied a bed that others needed, but releasing her without resolution carried its own risks. In response to the mounting pressure, Weiss attempted to structure the case more formally. He reviewed Army medical circulars dealing with psychosomatic disorders, traumatic injury, and gynecological complications common among displaced civilian populations. None offered a direct parallel. The closest category, conversion disorder, was broadly defined and often used as a default when physical causes could not be identified. Weiss was reluctant to apply it without further examination. He requested assistance from another medical officer temporarily attached to the hospital, a surgeon with experience treating civilian casualties in Italy. The consultation took place on September 3. The surgeon reviewed Anna's chart, conducted a brief examination, and concurred that there was no obvious orthopedic injury. He suggested the possibility of chronic pelvic inflammation or adhesions, but noted that confirming such a diagnosis would require an internal examination and imaging equipment not available at the facility. The recommendation was noted, but no immediate action followed. The hospital lacked the instruments, privacy, and trained personnel for such procedures. Moreover, the presence of an interpreter added complexity to any sensitive examination. Weiss was aware that consent, while formally required, was difficult to assess under occupation conditions. In the meantime, nursing staff attempted limited physical therapy. Anna was encouraged to sit at the edge of the bed and, with support, lower her feet to the floor. Each attempt ended the same way. Her upper body remained steady, but her legs did not respond. When pressure was applied to separate them, her breathing became shallow and her muscles tightened further. Nurses reported that she did not cry out or resist verbally, she simply became immobile. These sessions were discontinued after one nurse reported that Anna had fainted during an attempt. Weiss agreed that continued effort without a clearer understanding of the cause was counterproductive. Other patients in the ward began to notice the attention Anna received. Rumors circulated quietly. Some detainees assumed she was feigning illness to avoid transfer. Others speculated about hidden injuries. No one spoke to her directly about it. Anna herself remained reserved, speaking only when addressed by staff. On September 7, Weiss conducted another interview, this time focusing on Anna's service history. He asked about her assignments, movements, and living conditions during the final year of the war. The interpreter relayed each question carefully. Anna answered without embellishment. She described long periods of travel with supply convoys, frequent air attacks, nights spent in abandoned buildings or open fields. She mentioned hunger and cold but did not dwell on them. When asked about medical treatment during that time, she said there had been none beyond basic first aid. Weiss asked whether she had experienced illness affecting her lower body, fever, infection, injury. Anna paused before answering no. Her expression did not change, but Weiss noted the delay. He did not press the point further. The interview ended without revealing new information, but Weiss was left with the impression that Anna's account, while accurate in outline, omitted details. Whether those omissions were deliberate or unconscious was unclear. The following week brought further complications. An inspection team from the regional military government visited the hospital to assess compliance with occupation directives. During their review, they questioned the number of long-term patients and asked for justification. Weiss presented Anna's case as an example of unresolved medical necessity. One officer suggested that, in the absence of demonstrable physical injury, she be reclassified as fit for transfer. Weiss objected, stating that her inability to walk was observable and persistent. The officer countered that the holding camps could manage non-ambulatory detainees. The exchange remained formal, but the implication was clear. Medical discretion was expected to align with administrative efficiency. After the inspection, Weiss documented his concerns more thoroughly. He expanded his notes, detailing each failed attempt at mobilization and the absence of improvement over time. He emphasized that Anna's condition appeared involuntary and resistant to encouragement or discipline. Despite this, no additional resources were allocated. The hospital continued to operate with the same limitations. On September 14, an incident occurred that further complicated matters. During evening rounds, a guard reported that Anna had been found attempting to stand unassisted while the ward was unattended. She had fallen beside the bed and was unable to rise. When nurses arrived, they found her seated on the floor, legs still tightly drawn together, breathing rapidly. There were no new injuries, but the event reinforced Weiss's assessment that her condition was not under her conscious control. If it were malingering, it was a remarkably consistent and self-defeating one. Weiss ordered that Anna's bed be repositioned closer to the nurse's station and that assistance be provided whenever she needed to move. These measures reduced risk but did nothing to advance diagnosis. As September progressed, Weiss began to experience a growing unease. He had encountered many forms of wartime trauma, but this case resisted categorization. The physical findings suggested one thing, the patient's demeanor suggested another. The institutional framework within which he worked offered little flexibility for ambiguity. The tension became more pronounced when Weiss received a memorandum indicating that the hospital would soon be required to reduce its patient census by 15%. Names were to be submitted for priority transfer. Anna's name appeared on a preliminary list compiled by administrative staff. Weiss struck it out and returned the document with a brief note. Patient requires further evaluation. Transfer at this stage is inadvisable. No reply came immediately. Instead, Weiss was summoned to a meeting with the hospital's commanding officer who reiterated the importance of throughput. Weiss restated his position, carefully avoiding speculation. He argued only from an observed fact. The patient could not walk and the cause remained undetermined. The commanding officer listened without comment and dismissed him. That evening, Weiss reviewed Anna's chart once more. The accumulated notes described a condition that was static, unexplained, and increasingly inconvenient to the system managing it. He recognized that continued delay without progress would eventually be overridden. For the first time, Weiss considered that the limitation might not be discoverable through routine examination alone. There were categories of experience that patients did not volunteer and that doctors did not routinely ask about, particularly across language and cultural barriers. The thought was tentative, not yet fully formed. Weiss did not record it. He simply closed the chart and returned it to the rack. Outside, autumn had begun to settle over the hospital grounds. Leaves collected along the walkways, and the flow of detainees continued unabated. Inside the women's ward, Anna remained where she had been since August, her condition unchanged, her future unresolved. By the third week of September 1945, Captain Weiss's options had narrowed. Administrative patience was wearing thin, and the hospital's role as a temporary holding facility was being emphasized more strongly with each passing directive. Cases that did not move forward were increasingly scrutinized. Anna's case condition remained unchanged. Her daily routine had settled into a pattern. She woke early, accepted meals without comment, and spent long hours seated upright in bed, her back straight, her hands folded. She did not ask for favors or complain of discomfort unless directly questioned. When spoken to, she answered calmly, often with only a few words. The interpreter noted that her German was formal and restrained, lacking regional inflection. Weiss observed her more closely than before, not as a diagnostic exercise but as a matter of professional concern. There was no visible agitation, no overt signs of distress. Yet her posture never relaxed. Even during sleep, nurses reported, her legs remained rigidly together, as though held by muscle memory rather than conscious effort. On September 21, Weiss made an unofficial decision. It was not recorded as such, but it marked a shift in how he approached the case. During his medical training, discussions of sexual violence had been minimal. Such matters were rarely addressed directly, particularly in relation to enemy civilians. In the immediate post-war environment, allegations of abuse were politically sensitive and administratively inconvenient. They complicated classification and responsibility. Nevertheless, Weiss was aware, through reports, rumors, and personal observation, that sexual violence had been widespread during the collapse of Germany's eastern and central regions. The movement of armies, the breakdown of authority, and the displacement of civilians had created conditions in which abuse occurred with frequency, often unrecorded. He had treated victims before, though not always knowingly. Symptoms varied widely and were often attributed to other causes. Physical injury was not always evident. Psychological effects could persist long after the events themselves. With this in mind, Weiss arranged a private interview with Anna, requesting that it be conducted without guards present and with only a single female nurse, and the interpreter in attendance. This was irregular but not explicitly prohibited. The interview took place in a small examination room adjacent to the ward. Anna was assisted into a chair. She sat stiffly, her knees pressed together, her feet flat on the floor. Weiss positioned himself across from her, keeping his tone neutral. He began by explaining, through the interpreter, that he was trying to understand her condition so that appropriate care could be provided. He stated that some illnesses were not visible and that certain experiences affected the body in indirect ways. Anna listened without interruption. Weiss then asked a question he had avoided until now. He asked whether she had ever been harmed by another person in a way that affected her body. The interpreter paused before translating, choosing words carefully. When the question was relayed, Anna did not respond immediately. Her gaze remained fixed on the wall opposite her. Several seconds passed. The room was quiet except for distant sounds from the ward. When Anna spoke, her voice was steady. She answered that she had been harmed. She did not specify when or by whom. She did not use descriptive language. She said only that it had happened more than once. Weiss did not ask follow-up questions immediately. He allowed the interpreter to relay her words in full, then acknowledged them with a brief nod. He stated that he was sorry and that he would not ask her to describe anything she did not wish to describe. He then asked, gently, whether the harm had occurred before or after the onset of her inability to move her legs normally. Anna answered that it had occurred before. This was the first clear temporal link Weiss had obtained. He proceeded cautiously. He asked whether the pain she experienced when attempts were made to separate her legs was similar to pain she had felt during those events. Anna answered yes. At this point, the nurse present later recalled that Anna's breathing changed slightly, becoming shallower, though she did not otherwise show emotion. Her hands remained clasped tightly in her lap. Weiss concluded the interview shortly afterward. He did not attempt a physical examination. Instead, he explained that her condition might be related to involuntary muscle response following trauma and that forcing movement could worsen it. He assured her that she would not be compelled to undergo further attempts at walking without her agreement. Anna acknowledged this with a small nod. It was the first time Weiss observed any visible sign of relief. Following the interview, Weiss documented the conversation in deliberately restrained terms. He did not use explicit language. He noted history of personal violence and symptoms consistent with traumatic muscular response. He emphasized that the condition appeared involuntary and that aggressive intervention was contraindicated. He was aware that such documentation carried risk. Allegations of abuse raised questions about responsibility that the occupation authorities were often unwilling to pursue, particularly when perpetrators were unidentified or belonged to Allied forces. Weiss avoided speculation and confined his notes strictly to medical relevance. In the days that followed, Weiss adjusted Anna's care plan. Physical therapy was suspended entirely. Instead, she was encouraged to engage in simple relaxation exercises while seated, focusing on breathing and gradual release of tension. Progress was minimal but measurable. Nurses reported slight reductions in rigidity during rest, though no functional mobility returned. Word of the change in approach spread quietly among the staff. Some expressed skepticism. Others expressed relief that attempts to force improvement had ceased. No formal objections were raised. Administrative pressure, however, did not diminish. On September 28, Weiss received a written directive requesting a definitive recommendation regarding Anna's transfer status. He was asked to classify her condition as either temporary and resolvable or chronic and non-resolvable. Weiss understood the implication. A classification of chronic disability would likely result in prolonged institutionalization or transfer to a civilian care facility under German administration. A classification of temporary prisoners would justify removal to a holding camp, where medical oversight would be minimal. He did not yet feel able to make that determination. The limited improvement observed suggested that recovery might be possible, but the timeline was uncertain, and resources for appropriate treatment were scarce. Weiss delayed his response, citing the need for further observation. That same evening, he returned to the women's ward after official rounds had ended. He did not speak to Anna. He stood briefly at the doorway, watching as a nurse adjusted her bedding. Anna looked up and met his gaze. There was no expression on her face, but she did not look away. Weiss left without a word. The case had crossed a threshold. It was no longer a matter of unexplained symptoms, but of acknowledged trauma. The challenge now lay not in identifying the cause, but in determining what could be done within a system that was not designed to address it. October 1945 brought a shift in authority at the hospital. A new commanding officer assumed oversight as part of routine rotation, and with him came a renewed emphasis on procedural compliance. Medical officers were instructed to bring all unresolved cases to formal review. Informal discretion, tolerated during the immediate post-war period, was giving way to standardized reporting. A case file was scheduled for review during the second week of the month. Captain Weiss prepared carefully. He organized his notes chronologically, removing conjecture and focusing on observable facts. He included records of failed mobilization attempts, nursing observations, and his most recent assessment describing trauma-related muscular response. He did not include details of the interview beyond what was already documented. The review board consisted of 3 officers: the commanding officer, a medical administrator, and a liaison from the military government. None had examined Anna personally. The discussion was brief and procedural. Weiss summarized the case, emphasizing the persistence of symptoms and the lack of available treatment resources. He stated that forced transfer would likely worsen her condition and could result in injury. The liaison asked whether the condition could be considered psychological rather than physical. Weiss answered that the distinction was not clinically meaningful in this instance. The administrator asked whether prolonged hospitalization was justified in the absence of active treatment. Weiss responded that stabilization and prevention of harm were legitimate medical objectives. The commanding officer listened without interruption. When Weiss finished, there was a pause. The officer then stated that, while the medical concerns were noted, the hospital could not function as a long-term refuge. A decision would have to be made. The board requested that Weiss submit a final classification within 72 hours. Following the meeting, Weiss returned to his duties with a sense of constraint that had not been present before. The latitude he had exercised informally was narrowing. Any decision he made now would carry institutional consequences. He revisited Anna's condition with renewed attention. Over the previous 2 weeks, there had been modest changes. During periods of rest, her muscle rigidity lessened slightly. With encouragement, she was able to shift her legs a small distance apart while seated, though not without visible strain. Standing remained impossible. Weiss consulted with the nursing staff. Their observations were consistent. Progress was slow but real. More importantly, Anna's distress had decreased since attempts to force movement had ceased. She spoke more readily to the nurses, though still sparingly. On October 12, Weiss conducted one final interview. He informed Anna, through the interpreter, that a decision regarding her transfer was imminent and that he needed her input. He asked whether she believed she could tolerate transport to another facility. Anna considered the question carefully. She answered that she did not believe she could endure travel without significant pain and fear. She stated that she was not asking to remain indefinitely, only until she could move without force. Weiss asked whether she would consent to transfer if appropriate care were available elsewhere. Anna replied that she would, but she did not know where such care existed. The interview reinforced what Weiss already knew. There was no ideal outcome available within the current system. That evening, Weiss drafted his final recommendation. He classified Anna's condition as temporarily disabling with uncertain duration, a formulation that acknowledged both the seriousness of her impairment and the possibility of recovery. He recommended against transfer to a holding camp and suggested placement in a civilian medical facility under German administration, where longer-term care might be feasible. It was a compromise. It removed Anna from military custody without subjecting her to the conditions of a camp. It also transferred responsibility to a system that was itself overwhelmed and under-resourced. The recommendation was submitted the following morning. The response came 2 days later. The commanding officer approved the transfer, noting that civilian facilities were now being reconstituted and that cases such as Anna's fell within their remit. Arrangements were to be made within the week. Weiss was not consulted further. The news was relayed to Anna on October 17. She received it without visible reaction. When asked whether she had questions, she shook her head. The interpreter later remarked that her acceptance seemed less like agreement than resignation. Preparation for transfer proceeded methodically. A civilian hospital in a nearby city had agreed to accept her, though no details of treatment were specified. Transport would be by ambulance, with a nurse in attendance. On the morning of October 20, Weiss visited the women's ward earlier than usual. Anna was already awake. Her belongings were packed in a small canvas bag at the foot of the bed. Weiss spoke briefly, offering a formal statement of good wishes. He reiterated that her condition was recognized as real and that she was not at fault for it. The interpreter conveyed his words faithfully. Anna listened, then responded quietly. She thanked him for believing her. It was the first expression of gratitude Weiss had received from her, and it was delivered without sentiment. He acknowledged it with a nod. The transfer took place shortly thereafter. Weiss did not accompany the ambulance. His duties required him elsewhere, and there was no official role for him beyond that point. In the days that followed, the hospital continued its work uninterrupted. New patients arrived. Old ones departed. Anna's bed was reassigned within hours. Weiss requested an update on her condition through informal channels, but received none. Once transferred to civilian administration, patients often disappeared from military records. The system did not track outcomes beyond the point of handover. The case lingered with Weiss nonetheless. It had exposed the limits of his authority and the inadequacy of the structures within which he operated. He had acted within his understanding of medical ethics, but the result was partial at best. There were no reprimands or commendations. His actions were neither challenged nor endorsed beyond the immediate decision. The institution absorbed the case and moved on. As October drew to a close, Weiss prepared for reassignment. His tour at the hospital was ending, and he would soon return to the United States. The war had been over for months, but its unresolved injuries remained. Anna Kay was no longer under his care. Her future was uncertain, shaped by factors beyond his influence. What remained was the knowledge that, for a brief period, her condition had been acknowledged rather than dismissed. That acknowledgement, limited though it was, marked the furthest extent of what the system had allowed. The civilian hospital to which Anna Kay was transferred in October 1945 occupied a damaged but functioning building on the edge of a regional administrative center. Like many German medical institutions at the time, it operated under provisional authority, with oversight shared between local administrators and the Allied military government. Supplies were limited, staff shortages were severe, and patient intake far exceeded capacity. Anna arrived by ambulance accompanied by a nurse and a brief medical summary. The document outlined her mobility restriction, noted a history of trauma without elaboration, and recommended continued care without coercive physical intervention. No prognosis was offered. Upon admission, she was assigned to a women's medical ward rather than a surgical unit. There, she joined patients suffering from a range of conditions typical of the post-war months: malnutrition, untreated infections, chronic pain, and psychological collapse. Many had similar gaps in their histories. Few records from this period were comprehensive. Unlike the military hospital, the civilian facility did not operate under immediate pressure to clear patients for transfer. Stays were longer, though treatment options were more limited. Anna remained largely confined to bed during her initial weeks. Staff attempted no forced mobilization. Care focused on nutrition, hygiene, and rest. A German physician assigned to the ward later noted in her chart that Anna's condition appeared functional rather than structural, a common formulation at the time. The note did not dismiss the impairment. It simply acknowledged that no surgical remedy was apparent. Treatment, such as it was, consisted of gradual physical conditioning and what was then described as nervous calming. Progress was slow. Over the following months, Anna achieved small but significant changes. She was able to sit for longer periods with less rigidity. With assistance, she could shift her legs slightly farther apart than before, though standing remained difficult and painful. There were setbacks. Periods of improvement were followed by regression, often without clear cause. The hospital records indicate that she remained an inpatient into early 1946. By that time, civilian medical administration was undergoing further restructuring, and many patients were discharged to family care or local welfare systems. Anna's discharge date is not recorded in surviving documents, nor is her destination. What can be established is limited. There is no evidence that she received specialized trauma treatment as it would later be understood. Psychological care in post-war Germany was rudimentary, and discussions of sexual violence were often avoided or minimized. Recovery, when it occurred, was largely self-directed and uneven. Anna K. does not appear again in military or hospital records after mid-1946. Whether she regained full mobility is unknown. Whether she returned to work, remained dependent on assistance, or lived with chronic impairment cannot be determined from the available sources. Captain Harold Weiss returned to the United States in November 1945. He was discharged from active duty the following spring and resumed medical practice. In later years, he specialized in internal medicine and did not publish on wartime medical cases. No formal report was filed regarding Anna's case, and it did not feature in post-war analyses of military medicine. There is no indication that Weiss faced disciplinary action for his decisions, nor is there evidence that his handling of the case influenced policy. At the institutional level, Anna's experience was absorbed into the mass of unresolved post-war cases that passed briefly through Allied systems before disappearing into civilian life. Yet the case was not without quiet significance. In the immediate aftermath of the war, medical frameworks were poorly equipped to address injuries that lay at the intersection of physical trauma, psychological response, and social taboo. Symptoms that did not conform to visible wounds were often dismissed or misclassified. Women, particularly those associated with enemy forces, occupied an ambiguous position within occupation structures, their experiences frequently discounted. Within that context, Weiss's refusal to label Anna's condition as malingering or hysteria represented a modest deviation from prevailing assumptions. He did not resolve her condition, nor could he, but he recognized its legitimacy and acted to prevent further harm within the limits of his authority. That recognition did not lead to justice, restitution, or comprehensive care. It did not alter institutional priorities or generate lasting documentation. It did, however, ensure that one individual was not forced back into circumstances that would have compounded her injury. For Anna, the impact of that decision was immediate rather than enduring. It provided time not to heal completely, but to exist without coercion. In the aftermath of systemic collapse, such intervals were rare. The broader system moved on. By 1947, Allied occupation policies shifted toward economic reconstruction and political realignment. Early humanitarian improvisations gave way to standardized governance. Cases like Anna's, unresolved and unquantifiable, receded from view. They survive, if at all, in fragments: an intake card, a medical note, a recollection preserved indirectly through later testimony. They do not lend themselves to clear narratives of recovery or failure. They resist closure. Anna K. was one among millions whose bodies carried the war beyond its official end. Her impairment did not alter campaigns or treaties. It did not enter official histories. It existed in hospital wards, in brief professional judgments, and in the unrecorded years that followed. Her story illustrates not an exception, but a pattern. War injuries are not confined to the battlefield. Some remain unclassified, unresolved, and unacknowledged long after surrender documents are signed. The legacy of such cases is quiet. It resides in the limits of institutions and the small, discretionary acts of individuals working within them. It is measured not by outcomes, but by restraint. If this account contributes to a fuller understanding of those overlooked experiences, consider supporting continued documentation of forgotten wartime lives by subscribing to the channel.